Imagine you're drawing your radiation target volumes and you feel completely confident.
Right, you think you've got everything covered.
Exactly. You think you've covered all the microscopic disease, but then you realize later that your surgeon backed away from a highly curable, totally resectable case.
Oh, man.
Yeah.
Let me guess, because a single lymph node was mislabeled.
Yes, mislabeled by just a millimeter on some late-night pathology report. So a patient's entire curative pathway is just, well, it's permanently derailed by geography.
It's devastating, and it happens more than you'd think.
It really does. So welcome back to Red on Smart Review, Thoracic Edition. Today, we're tearing down and completely rebuilding how we think about nodal anatomy and invasive mediastinal staging.
Because, for everyone listening, this isn't some trivia game. It's not about memorizing numbered dots on a cartoon map.
Right. It's way more than that.
It is. It's about establishing this really rigorous chain of custody for anatomic truth. You have to, link physical anatomy to imaging probability, right? And then link that to procedural access, then to tissue adequacy, and finally to those irreversible treatment consequences.
And if any single link in that chain breaks,
the entire curative intent pathway just collapses, especially for a patient with non-small cell lung cancer.
Yeah, exactly. So for those of you listening, whether you're contouring a definitive chemoradiation plan tomorrow morning, or maybe you're prepping for your oral boards, you cannot simply look at a PT scan and point to the glowing spots.
No, you absolutely cannot.
So we're going to deconstruct this entirely through a specific high-stakes case today. Just picture this patient sitting right in your consult room.
Okay, let's hear it.
So we have a patient with suspected non-small cell lung cancer, right? And they're being evaluated for curative intent treatment. We get the contrast-enhanced chest CT and the FDG PE scan.
Standard workup, yeah.
Right. And both of those imaging modalities identified this suspicious left upper mediastinal node. It's sitting right near the trachea and the aortic arch.
Which is exactly where the fundamental conflict of our case begins, right?
Oh, totally. Because the radiology report comes back and they definitively call this node station 4L.
Okay, 4L.
But then, you look at the pulmonology procedural note from the staging biopsy, and the pulmonologist states the sampled node was station 5.
Wow. Right, so already we have a major geographic discrepancy between basically the map maker and the navigator.
Exactly. And it actually gets worse when we look at the pathology results.
Oh, of course it does.
Yeah. So station 7, the subcarinal node, that was also sampled during the procedure, and it's reported as negative.
Okay, that's helpful at least.
But the specimen from that left upper mediastinal, finding the one called 4L by RADS and 5 by pulmonology, that specimen contains scant material.
Oh.
Yeah, the pathology report literally just reads, no malignant cells identified.
Which, we both know is a huge red flag.
It's the hinge point of the entire case, because it does not establish that the scant material adequately represented actual lymph node tissue.
So when this exact patient, lands in your clinic for a radiation oncology consult, you have to completely reframe the problem for yourself.
Right. The question isn't just, was the EBUS negative?
Exactly. The real consult question you have to answer is, was the recommendation-changing node correctly identified, actually reached, and adequately sampled before we commit this patient to a pathway?
Because once you go down the surgical or definitive radiation pathway, it's irreversible.
Completely irreversible.
So let's give everyone listening the 60-second board answer before we, really tear this case apart piece by piece. How are we definitively handling this ambiguity?
Yeah. Okay, so the board-level answer is this. First, I would confirm the diagnosis and actually review the diagnostic CT and FDG PET directly with thoracic radiology.
Great. Get everyone on the same page.
Exactly. Reconcile the anatomy. Then I'd explicitly document that the AJCC version 9 governs any nodal category I'm assigning.
Version 9, super important.
Yeah. And I would absolutely not treat PE data avidity as pathologic proof of disease. Period.
That's a huge trap.
It is. And furthermore, I wouldn't just blindly accept the phrase negative staging without reviewing exactly which stations were examined, which were sampled, and if the tissue was actually representative.
Because, that left upper mediastinal finding could dictate whether this is an upfront surgical case or if they need definitive chemoradiation. We need invasive staging.
We do. And the procedure has to match the reality. Invasive staging is unequivocally indicated here.
So what's the contemporary approach for that?
Well, based on the 2026 guidelines, the first-line approach is endosonography, rather than just going straight to a mediastinoscopy. assuming, of course, the ultrasound tools can actually answer the question.
Right, and the exam has to be systematic, not just poking the hottest node on the PT scan.
Exactly, using combined airway and esophageal access when it's feasible.
But looking back at our specific patient, before we just reflexively order a repeat procedure because the first one was scant, we have to resolve the geography. Is it 4L or is it station 5?
Right, because those numbers describe entirely different anatomical spaces.
Totally different. And they require completely different access tools. Plus, regarding that scant specimen, it's non-diagnostic. It is not a reliable negative.
Precisely. I mean, I wouldn't order a routine confirmatory mediastinoscopy just because one ultrasound result was negative. But this specific case,
It's got unresolved anatomy.
unresolved anatomy,
Mm.
inadequate tissue, and massive residual clinical concern. It absolutely requires multidisciplinary escalation.
We need a route that can actually reach the decisive station, whatever it takes.
Yeah, and if representative tissue eventually confirms malignancy, then I revise the pathway and carry that exact positive station into my radiation planning.
And if it's truly negative,
If a systematic, adequate evaluation is truly negative, then I proceed with the curative pathway while documenting that residual uncertainty.
that is exactly how you synthesize this safely. But to do that synthesis, you need a really deep, fundamental understanding of the physical space. We have to start with the map, not the scope.
I love that. The map, not the scope.
Because the label given to a node dictates two massive things for us. First, its staging category under AJCC version 9. And second, the physical surgical instrument required to reach it.
Right, because a nodal station is a three-dimensional anatomic volume bounded by fixed structures.
Yeah.
The trachea, the carina, the aortic arch.
It's not just a two-dimensional glowing dot on a screen.
Exactly. So let's actually walk through the cranial to caudal breakdown of this map. It's easiest to start from the top and descend into the chest.
Sounds good. Let's start with station 1.
So station 1 is the low cervical and supraclavicular region. In 3D space, it extends from the lower border of the cricoid cartilage superiorly down to the clavicles and the upper border of the manubrium inferiorly.
Okay, so low cervical, supraclavicular, sternal notch nodes.
Yep. And for station 1, right and left are divided strictly by the tracheal midline.
And for those of you listening, we really need to pause here and emphasize what station 1 actually means for a patient's survival and treatment.
It's huge.
A supraclavicular node isn't just some generic high mediastinal node. It is a distinct station with major N3 implications.
An N3 designation fundamentally shifts the patient's entire trajectory. Like, if you have a true supraclavicular node, you are firmly in stage IIB or IIC territory, depending on the primary T stage.
Which generally means they're definitively inoperable.
Right. You're shifting entirely away from primary surgery and moving into definitive concurrent chemoradiation, followed by immunotherapy. So the stakes of identifying station 1 correctly are absolute.
Wow. Okay, so moving inferiorly into the true mediastinum, we hit stations 2 and 4, the paratracheal station.
Right. 2R and 2L are upper paratracheal. 4R and 4L are lower paratracheal.
And they're organized around the thoracic inlet and manubrium up top. Then as you go down, they're bounded by major vascular architecture.
Yeah, the innominate vein, the aortic arch, zygos vein, left main pulmonary artery, and finally down to the carina.
Which brings us to, honestly, what might be the single most important high-yield rule of mediastinal geography.
Oh, the shifting line.
Yes. Below station 1, the dividing line between right and left changes. The left lateral border of the trachea becomes the practical dividing line between right-sided and left-sided paratracheal stations.
It's completely counterintuitive if you're just thinking about bilateral symmetry.
Right. I always think of this like a shifting state line on a highway. Above the thoracic inlet, up in station 1, the state line is right down the middle of the highway, the tracheal midline. But once you drop below the sternal notch into the mediastinum for stations 2 and 4, that state line shifts all the way over to the left shoulder of the road.
The left lateral border of the trachea. That analogy perfectly captures the anatomical reality.
And the clinical implication is catastrophic if you misunderstand it.
Oh, definitely. Let's say a node sits slightly left of the tracheal midline, but it hasn't physically crossed the left lateral border of the trachea yet.
It's still technically a right-sided node.
Exactly. It's a 2R or 4R. But residents and even seasoned attendings frequently fall into the trap of just using the tracheal midline for every paired station in the chest.
And if you do that,
You can accidentally turn an ipsilateral N2 node into a contralateral N3 node on paper without the anatomy actually changing at all.
think about the real-world consequence of that error for a second. You're contouring that node or presenting at tumor board, And you confidently call it a contralateral 4L node for a right-sided primary tumor.
Everyone in the room instantly assumes N3 disease.
Exactly. The thoracic surgeon immediately backs away from a potentially highly resectable case. The med-onc starts talking about definitive chemoradiation, all because you drew the dividing line in the middle of the airway instead of the left lateral border.
It's a devastating, irreversible error based purely on geographic ignorance.
Okay, let's keep descending. Station 3.
Station 3. This one is incredibly easy to forget or misclassify because it's not just another paratracheal box hugging the windpipe.
Right, it's divided into 2 distinct compartments.
Yes. Station 3A is prevascular, sitting anterior to the great vessels like the superior vena cava. And Station 3P is retrotracheal, sitting completely behind the trachea.
But practically speaking, why does distinguishing 3A and 3P matter so much when you're reviewing a procedural note? I mean, why can't we just lump them into the upper mediastinum?
Because of how the pulmonologist physically accesses them. A node that's anterior to the SVC in that 3A compartment should never be casually relabeled as a 2R or 4R just to make the chart look clean.
And what about 3P?
Well, a 3P node directly behind the trachea poses a massive physical challenge. If a node generically says upper mediastinum sampled, but the PET shows a retrotracheal 3P node, you have a problem.
Because a standard airway ultrasound scope has a terrible angle trying to sample 3P through that tough posterior membranous wall of the airway.
Exactly. You need to know exactly where the disease lives to know if the tool could have possibly reached it.
Which brings us to the left-sided aortic stations. This is the absolute crux of our case anchor today, Station 5 and Station 6.
Let's define the borders carefully for these.
Yeah, so Station 5 is the subaortic station, commonly called the aortopulmonary window station. It lies beneath the aortic arch, above the left pulmonary artery, and out in the lateral vascular window near the ligamentum arteriosum.
And just adjacent to that is Station 6, the para-aortic station. It sits alongside the ascending aorta and the aortic arch, anterior and lateral to the vessels.
And here is the critical, non-negotiable takeaway for anyone listening. Stations 5 and 6 are absolutely not interchangeable with 4L.
Not even close. 4L is in the left paratracheal compartment. It tightly hugs the left wall of the airway. Station 5 is completely separate. It's out in the AP window, pushed laterally and bounded by major high-pressure vascular structures.
This is exactly why our case patient is sitting in clinical limbo right now. The suspicious node is near the left trachea and the aortic arch, but the word near does not dictate the biopsy tool.
Right. We need to know if it hugs that tracheal compartment, making it a 4L. Because if it is a 4L, an endobronchial ultrasound and EBS can easily poke a needle through the airway wall to sample it.
But if it sits way out in the AP window, making it a Station 5,
then a route that reliably samples 4L through the airway will be completely blind to a Station 5 node. The aorta and pulmonary artery physically block the needle path.
Okay, moving further down the map, we hit the carina, where the trachea bifurcates. That's Station 7, the subcarinal station.
It begins below the carina and occupies the space between the right and left main bronchi. Its inferior boundary is related to the lower border of the bronchus intermedius on the right and the upper border of the lower lobe bronchus on the left.
And as we descend even deeper into the lower mediastinum, I want to share a highly practical oral board sequencing mnemonic for these central descending nodes.
Oh, I know this one. It's a lifesaver.
Yeah. If you are tracking a node inferiorly, just remember CSPP carina, subcarinal, which is 7, paraesophageal, which is 8, and pulmonary ligament, which is 9.
It's a phenomenal tool for keeping your bearings. Station 8 runs tightly along the esophagus wall, heading straight down toward the diaphragm.
And Station 9.
Station 9 lies within the pulmonary ligament, extending from the inferior pulmonary vein down toward the diaphragm. So if you're looking at a scan and a node is well below the subcarinal space and tracking along the esophagus, you cannot just lazily call it Station 7 because it happens to be centrally located.
Right. And if it lies below the inferior pulmonary vein, Station 9 has to be at the top of your differential.
Exactly. So finally, we clear the mediastinum and move into the hilar and intrapulmonary stations.
Stations 10 through 14.
Right. Station 10 is hilar, right at the main stem bronchi. Station 11 is interlobar. Station 12 is lobar. 13 is segmental, and 14 is subsegmental. The numbers basically just march outward with the branching of the bronchial tree.
And just to briefly anchor these to the N categories of staging, for our listeners, ipsilateral stations 10 through 14 are N1 disease.
and ipsilateral mediastinal and subcarinal involvement, so your stations 2, 4, 5, 6, 7, 8, and 9, that's N2 disease.
Contralateral mediastinal or contralateral hilar involvement, or any supraclavicular involvement in station 1, is N3 disease.
We aren't doing a comprehensive deep well, a full review on stage group translation today, but we highlight those categories to show exactly why exact station and laterality matter.
Because a shift of just a few millimeters across a vascular boundary can change a patient from N1 to N2 or N2 to N3.
The entire point of this geographic exercise is to make sure the data entering your staging algorithm is the absolute truth.
Which leads perfectly to the major clinical pearl of this mapping section. Whenever you are reviewing imaging, you should always describe a node in 2 languages before you ever assign a number to it in a clinical chart.
I preach this to my residents constantly. 2 languages. First, describe it by its fixed anatomical relationships. Like, this node is located left of the trachea, beneath the aortic arch, and above the left pulmonary artery.
And then, and only then, assign the station number based on those borders. Therefore, it is station 5.
Yes. If your verbal anatomical description and your station number do not match, that station number should not survive the node.
Do not just copy and paste what the radiology resident typed into the preliminary report at 2 in the morning.
Please don't. Verify the borders yourself.
Okay, so that transitions us from the map to the tools. We need to talk about procedure selection, matching the route to the reality.
Right. Now that we know where the node truly lives in 3D space, we have to recognize that one tool cannot reach every room in the house. We have to pivot from anatomy to the technical, physical realities of tissue acquisition.
And the very first question we have to answer for any patient is, does this patient even need invasive mediastinal staging?
We can't just say the patient has lung cancer, so let's scope them.
Exactly. Invasive staging carries risks. It requires anesthesia, it delays treatment, it's indicated when the pretest probability of nodal disease is meaningful, when the result will actually change your clinical management, and when the patient can physiologically tolerate the procedure.
Let's break that down into probability and consequence. FDG PET is an incredible modality for estimating probability and designing the roadmap. But, and we have to repeat this until we're blue in the face, PET is not pathology.
It is not pathology.
PT-positive nodes can be entirely inflammatory. They can be reactive. Think about a lung cancer patient who also has severe COPD or a recent post-obstructive pneumonia.
Their mediastinum might light up on a PET scan like a Christmas tree purely from inflammation.
Exactly. PT tells you where the metabolic concern is concentrated.
Yeah.
It does not grant you permission to skip a biopsy when a positive finding would completely redirect a curative pathway from surgery to chemoradiation.
But on the flip side, we don't invasively stage every single patient who walks through the door.
No, definitely not. If you have a truly peripheral 1 centimeter T1 lesion, no suspicious nodes on the CT, a totally cold mediastinum on the PET scan, and low overall clinical risk, you can reasonably proceed directly to SBRT or primary surgery without invasive staging, assuming the tumor board agrees.
So the decision to stage isn't just a universal tumor size cutoff. It depends on the quality of the imaging, the tumor location. Central tumors have a drastically higher rate of occult N2 disease compared to peripheral ones.
It depends on the presence of Hiller disease, the patient's individual risk factors, and crucially, whether finding nodal disease actually changes the plan.
Right. If the patient is 85 years old, on continuous home oxygen, and physiologically too frail for systemic chemo or surgical resection, regardless of what the notes show, then an invasive procedure adds significant burden without adding a shred of clinical value.
So for those of you listening, the gold standard sentence you want to use when presenting at tumor board is, I recommend invasive staging because the probability of nodal disease is clinically meaningful, the pathologic result will fundamentally change the curative treatment pathway, and the patient can safely undergo a procedure capable of answering the question.
That's a great sentence to have in your back pocket. And for radiation oncologists specifically, we have to be incredibly cautious about letting PET scans define our entire mediastinal target volume.
Oh, we absolutely have to talk about the seismic study here. This is a critical piece of literature.
Let's unpack it.
So they looked at patients with locally advanced or unresectable non-small cell lung cancer who were candidates for definitive radiotherapy. And they mandated systematic endobronchial ultrasound sampling for these patients, completely, regardless of what the PT scan showed.
And the results were completely paradigm shifting. What did they find?
They found significant rates of PT occult nodal disease, meaning Nodes that were completely cold and looked benign on the P scan were actually harboring microscopic cancer cells when they physically biopsied them.
Wow.
This fundamentally changed the radiotherapy planning. It redefined mediastinal involvement compared to just drawing circles around the glowing pixels on the PT scan.
Think about the massive dosimetric implications of that for us drawing our target volumes. If you just contour the glowing peat nodes, the seismic study tells you that you are likely missing microscopic disease in adjacent cold stations.
Exactly. Tissue-informed staging can reveal disease that PP completely misses, which means your CTV, your clinical target volume, needs to respect the pathology and the lymphatic drainage pathways, not just the metabolic imaging.
So once we decide to invasively stage, we have to choose the route. And a common resident trap here is collapsing two very different questions. Where's the node? And what procedure do we usually order at our hospital?
Those are not the same thing at all.
So let's lay out the contemporary guidelines. The 2026 guideline default is endosonography first over traditional surgical mediastinoscopy, assuming it can answer the question.
Right, because it's minimally invasive, it's safer, and it provides real-time ultrasound guidance. But we have to match the tool to the specific anatomical station. Let's start with EBUS-TBNA endobronchial ultrasound with transbronchial needle aspiration.
So this goes down through the airway.
Yes, and it easily and reliably reaches stations 2, 4, 7, and 10. It's a phenomenal tool for paratracheal and subcarinal disease.
But then you have endoscopic ultrasound, or EUS, which goes down through the esophagus.
And it complements the airway approach perfectly. EUS and its variant EUS-B can reach stations 4L, 7, 8, and 9, and sometimes 2L.
But notice what is glaringly missing there.
Station 4R.
Right. Station 4R is a massive blind spot from the esophagus because the trachea and major vascular structures are completely in the way.
So you use EBUS for the right paratracheal side, and you can use EUS for the lower mediastinal or left-sided nodes.
Which is exactly why the 2026 Joint Endosonography Guidelines heavily favor combining EBUS with EUS in a single session when it's feasible and relevant.
It's not about doing two procedures just maximize RVUs and bill for them. It's about using complementary routes when the required anatomical map crosses the blind spots of either route alone.
But let's be explicitly clear. Combining EBUS and EUS still does not reach every station in the chest.
No, it doesn't. And this brings us right back to the station 5 and 6 access problem that is plaguing our case anchor. A clinically decisive aortopulmonary window node, station 5, or a para-aortic node, station 6, cannot reliably be hit from the airway or the esophagus. They are sitting out in that lateral vascular space.
The ultrasound waves just cannot penetrate the air in the lungs or the thick blood in the aorta to give you a safe needle path.
Right, but this creates a massive physical barrier. Neither the airway nor the esophagus gives you a clean shot at stations 5 and 6 because of those vascular structures.
That means we have to involve thoracic surgery or interventional radiology, right?
Exactly. Often these lateral nodes require a specific surgical approach. A left anterior parasternal mediastinotomy, classically known as the Chamberlain approach, is the traditional surgical route to stations 5 and 6.
Let's actually detail what a Chamberlain is so listeners understand the physical toll it takes on a patient. It is not a quick outpatient scope.
Not at all. It involves a surgical incision directly next to the sternum, usually over the second or third costal cartilage. The surgeon literally resects a piece of the rib cartilage to enter the extrapleural space. Yeah, they have to carefully navigate past the internal mammary vessels to go straight down into the AP window to physically grab that station 5 or 6 node. It is an open surgical staging procedure with real recovery time.
I want to push back on a piece of older dogma right here because I still hear this quoted confidently in tumor boards by senior attendings. The old rule was always, if the EBUS is negative, you must automatically order a confirmatory cervical mediastinoscopy.
Oh, yeah. We used to treat mediastinoscopy as the ultimate infallible gold standard that must follow any negative ultrasound.
And we absolutely have to correct that mindset. That dogma is outdated. The current guidelines do not support reflexively appending a surgical mediastinoscopy to every negative EBUS.
That old reflex completely ignores the quality of the ultrasound procedure, the adequacy of the tissue obtained, and the physical consequences of subjecting a patient to additional general anesthesia and surgery.
Cervical mediastinoscopy is highly valuable if endosonography is completely unavailable, or if the ultrasound can't physically reach the decisive station, or if the tissue obtained was grossly inadequate.
Right, but we only escalate to surgical staging based on unresolved anatomy, inadequate tissue, and clinical consequence, not just some blind algorithmic reflex.
So when you are looking at a patient's scan and choosing a route, You have to mentally separate four distinct questions. First, anatomic access. Can the instrument physically reach the station?
Second, procedural capability. Does your local pulmonology or surgery team have the specific expertise to perform this approach safely?
Third, tissue adequacy. Can this method obtain representative diagnostic material?
The fourth, clinical consequence. Will the result actually change your radiation fields or the surgical recommendation?
Because a node can be perfectly visible on the ultrasound screen, but poorly sampled by the needle.
Or a specimen can be highly adequate but pulled from the wrong anatomic station.
Or you can have a perfectly sampled, correctly labeled node that is completely low value because the answer doesn't change your radiation fields or systemic therapy integration anyway.
Those are all entirely different failure modes in the staging pathway.
Which is why, as a radiation oncologist, you should never write a lazy consult request that just says, please do EBS.
Oh, that drives me crazy. You need to explicitly state the clinical question for your proceduralist. Your consult should read, please perform systematic endosonographic mediastinal staging with particular attention to the suspicious left paratracheal and subcarinal stations, and use complementary esophageal access if needed to clear the AP window.
Exactly. That creates a standard of care, which leads us seamlessly into the next critical concept, the chain of custody and the negative fallacy.
Because having the right tool on the right route means absolutely nothing if the tissue obtained in the syringe is garbage.
A false negative right here can entirely ruin a curative intent pathway.
To understand tissue adequacy, we first have to differentiate targeted staging from systematic staging.
Okay, let's define those.
Targeted staging means the proceduralist goes in, looks at the PT scan, scopes the patient, biopsies the one single node that was glowing, and stops.
And systematic staging.
Systematic staging is the minimum acceptable standard. It means evaluating all clinically relevant stations needed to clear a pathway completely, regardless of whether they were avid on the PET scan.
The 2026 guidelines push heavily for systematic staging. Now, systematic doesn't mean you just memorize a universal number of nodes and blindly poke them all.
No, definitely not. It means you look at the primary tumor location, you figure out the expected lymphatic drainage pathway based on anatomy, and you systematically sample those specific stations to definitively exclude microscopic disease that would change your radiation plan.
So, before the procedure even happens, you should make a 3-column list in your head. Column 1, what does the imaging show? Column 2, why does each specific station matter for this specific patient's operability? Column 3, which physical route can safely reach it?
And after the procedure, you have to make sure every single specimen preserves its station-specific label all the way through the pathology lab.
If the final pathology report just spits out a generic mediastinal nodes negative, all that nuanced, hard-fought anatomical information is completely erased.
Let's rigorously define what we mean by the pathology results, because this is where the terminology gets incredibly dangerous. We have 3 categories we need to keep strictly separate in our minds.
Okay.
Category 1 is positive. This means malignant involvement has been definitively established in a correctly labeled anatomic station.
Pretty straightforward.
Category 2 is adequate negative. This means representative nodal material, meaning actual lymphocytes and nodal architecture from the intended station was obtained, and no malignancy was found.
Right. I hear you, but telling an anxious patient we didn't get enough tissue sounds exactly like the doctor made a mistake. How do we explain that third category, the non-diagnostic specimen, without destroying their trust in the surgical team? Because that third category is the trap.
It really is the trap. Non-diagnostic or inadequate means you got non-representative tissue. Maybe it's just scant blood. Maybe the needle just scraped some bronchial epithelial cells from the airway wall.
The pathology report might literally say at the bottom, no malignant cells seen. But in this specific context, that is not a negative result.
Exactly. It just means you didn't biopsy a tumor. It doesn't mean you successfully biopsied a healthy lymph node. You frame it around the microscopic anatomy for the patient, not operator error. You explain that lymph nodes are tiny, mobile targets, and sometimes the needle yields fluid rather than core cellular architecture.
That makes sense.
But you are absolutely right about the danger of the report itself. Calling that third category negative creates massive, system-wide false reassurance. In thoracic oncology, that false reassurance changes surgical intent, alters chemotherapy sequencing, and shrinks radiation volumes inappropriately.
Let's pull this directly back to our case anchor patient. Our patient had station 7 sample, and the pathology report confirms it was adequately negative. It had actual nodal tissue, and there was no cancer. Excellent.
But the station 4L5 sample was reported as scant material, no malignant cells. That is strictly non-diagnostic.
One valid negative station, station 7, does not miraculously validate a different inadequate station. That left upper mediastinal node remains completely unresolved, and the patient is still in limbo.
To intelligently interpret a negative study, you have to ask yourself 5 mandatory questions.
What are they?
Number 1, was invasive staging actually indicated? And was the clinical question clearly stated to the pulmonologist?
Right. Number 2, were the decisive stations anatomically reached by the chosen instrument?
Number 3, was the examination truly systematic rather than restricted just to the PET targets?
Number 4, was each specimen representative and adequate upon pathologic review?
And number 5, is the final result concordant with the CT, the PET, and the overall clinical risk of the patient?
The confidence you place in the word negative should plummet every single time one of those answers is no. I like to frame this entire process as a chain of custody for anatomic truth.
That's a great way to put it.
Think about it like a forensic evidence trail in a legal case. The exact node seen by the radiologist on the PET scan, targeted by the pulmonologist with the ultrasound, sampled for the pathologist, discussed by the oncologist at tumor board, and finally contoured by you, the radiation oncologist. It must demonstrably be the exact same node.
Every handoff between specialties is a chance for station drift.
Station drift is a phenomenal term for it. And the correct clinical response to a negative EDUS is not simply stop, and it's certainly not always do a surgical mediastinoscopy.
The correct response is to carefully judge the quality and context of the procedure. If you have pattern 1, the mediastinum is PET negative, the clinical risk is low, and a systematic, adequate EBIOS is negative, you can safely proceed with treatment. That is a genuinely reassuring negative.
But what about pattern 2? Let's say a heavily PT-avid node is correctly targeted, the proceduralist gets a great sample of actual lymph node tissue, and the pathologist says it is definitively negative for cancer.
That is genuine discordance between imaging and pathology. The PET said cancer, the microscope says no.
So what do?
You take that case immediately back to the multidisciplinary tumor board, review the images directly with radiology, look for benign inflammatory explanations like sarcoidosis or a fungal infection, and decide as a team if another invasive route is justified, or if you trust the pathology over the PT.
But our anchor case is pattern 3. The PT-avid node was either never physically reached due to the 4L5 confusion, it was mislabeled, or it yielded scant, non-representative material.
That station has not been cleared. It is incomplete staging, not a reassuring negative. And we have to remember that false negative risk isn't just about the resolution of the ultrasound machine.
Right. It stems from difficult anatomy, failure of the needle to penetrate the intended node, microscopic low-volume disease that the needle missed, or just basic labeling errors in the lab.
Which means when a proceduralist quotes you the theoretical sensitivity or negative predictive value of EBUS from a textbook, it is pretty useless unless you know exactly how the examination was actually performed on your specific patient.
And we cannot forget the opposite discordance either. If a pedicult node, a totally cold, normal-looking node, comes back pathologically positive for cancer, you have to believe the pathology.
Confirm the label, ensure there wasn't a specimen mix-up, but let it change your management. Do not dismiss a positive biopsy just because the PDT was negative. Remember the seismic study we discussed earlier?
Exactly. Microscopic disease does not always metabolize enough sugar to glow on a PET scan. This brings us to the hardest part of the job: clinical translation and patient counseling.
Yeah, this is where the rubber meets the road.
We have spent all this time establishing these strict rules of staging, anatomy, and adequacy. But how do 2 radiation oncologists synthesize this mess of conflicting reports into actionable radiation target volumes? And more importantly, a coherent conversation with a terrified patient sitting in front of them.
Let's talk about the radiation target impact first. If I am reviewing a patient's chart and I read a generic note from another provider that says mediastinum negative, that is completely useless for my target volume review.
I completely agree.
I need an actionable safety statement that addresses the anatomy. For our case anchor, my clinical note needs to explicitly read: Station 7 is adequately negative. Station 4L5 remains unproven due to conflicting procedural labeling and inadequate tissue yield. Treatment cannot proceed as if the left upper mediastinum has been cleared.
That sentence is bulletproof. It tells your dosimetrist, your clinical partners, and the thoracic surgeons exactly where the geographic uncertainty lies. And it impacts the massive distinction between operability versus resectability.
We will dive much deeper into this in our next review session, but briefly. Nodal status informs anatomic resectability, meaning, based on the tumor's map, can the surgeon physically remove the disease with clear oncologic margins?
It does not inform medical operability, which asks if the patient's heart and lungs can physiologically survive the trauma of the surgery. Nodal staging is entirely about the tumor's physical map, not the patient's pulmonary function tests.
So how do we counsel our anchor case patient? They just went through an uncomfortable EBUS procedure, they are highly anxious waiting for results, and now we have to walk into the room and tell them we still don't have the final answer.
You have to be honest, empathetic, but highly structured in your explanation. I would sit down, look at the patient, and say, we have some clear answers and some areas where we need more information. One lymph node under the center of your gestation 7 was adequately tested, we got great tissue, and is completely cancer-free. That is great news.
That's a good start.
However, a second node near your windpipe and aortic arch is more complicated. The procedure reports disagree on the exact physical location, and the tissue the needle obtained was too limited to prove it was actually a lymph node. Because this specific node changes our entire approach, whether we recommend upfront surgery or definitive radiation, we cannot guess. We need to review your images with the whole surgical team and safely get a proper sample.
That is fantastic communication because it separates what is definitively known from what remains physically uncertain. And most importantly, it sets the stage to justify the burden of a second, potentially surgical staging procedure to the patient.
But let's explore that physical burden, because patients absolutely hate repeat procedures. There is real toxicity. There is a delay in starting their definitive treatment. There is the agonizing anxiety of waiting another 2 weeks for pathology.
It's awful for them.
How do you, as an oncologist, balance the morbidity of a repeat procedure, maybe even escalating to an open surgical Chamberlain procedure, against the need for nodal certainty?
It is a critical, delicate balance. While utilizing combined EBUS and EUS upfront drastically reduces the need for serial procedures, sometimes you still fall short of the truth.
Escalating to surgical staging like a Chamberlain is a major decision. It requires general anesthesia, a sternal incision, and recovery time. The toxicity is real.
But you have to weigh that against the alternative, which is treating blindly based on an assumption. If you treat a patient who actually has a Colt N2 disease with surgery alone, they will almost certainly fail locally and systemically. You haven't cured them.
And on the flip side, if you radiate a patient who actually had a negative mediastinum, but you assumed it was positive because of a glowing PET scan, you are subjecting their healthy heart and lungs to massive, completely unnecessary radiation fields, causing lifelong toxicity.
Right. So the burden of the repeat procedure is only justified if it answers a management-changing question. You never do it reflexively. If finding cancer in station 5 won't actually change your decision to give definitive chemoradiation anyway, then do not subject the patient to a Chamberlain.
Precisely. The procedure must serve the treatment plan, not just satisfy our intellectual curiosity. Let's synthesize all of this. Let's move into our rapid review and the board blitz.
Let's do it.
Let's distill all this complex logic into the high unit takeaways that actually change management and help you pass your oral boards. We have 3 major oral board traps that examiners love to test. Trap number 1, treating PET scans as definitive pathology and sampling only the hottest node.
The faulty, dangerous conclusion here is believing that metabolic activity proves malignancy and completely defines the entire nodal burden.
The correction for Trap 1 is that you use PET purely to estimate probability and design your procedural roadmap. You must obtain physical tissue and perform systematic staging, because PET-positive nodes can easily be false positive inflammation, and totally PET-negative nodes can harbor microscopic occult disease.
Trap number 2, giving a binary, unnuanced answer to a negative EBUS. A resident under pressure might say, the EBUS is negative, so proceed to surgery. Or, a negative EBUS always requires a confirmatory mediastinoscopy.
Both of those are incredibly weak answers because they completely ignore tissue adequacy and clinical concordance.
The corrective reasoning for Trap 2 is to systematically pause and ask the 5 questions. Which stations were physically reached? Was it a systematic exam? Was each specimen representative of a true lymph node? And does the result fit the clinical risk? Routine add-on mediastinoscopy is outdated dogma. You only escalate for inadequate or highly discordant cases.
Trap number 3, naming a nodal station without naming its anatomical landmarks or access route. The trap is blindly believing that a node called 4L in one report is definitively 4L, even if its actual physical location on the scan is way out in the aortopulmonary window.
The correction for trap 3 is to describe the node relative to fixed anatomy. First, the trachea, the arch, the pulmonary artery, and only then assign the station number. You must physically reconcile labels across radiology, pulmonology, and pathology before initiating any irreversible treatment.
Okay, here are your 6 board pearls summarized quickly. Pearl 1. Nodal stations are fixed, 3D anatomical volumes, not glowing peak dots or blindly copied numbers.
Pearl 2. Know the cranial caudal map perfectly, especially the shifting left lateral tracheal border rule for the paratracheal nodes and the CSPP descent for the central nodes.
Pearl 3. Endosonography is your contemporary first-line invasive staging tool.
Pearl 4. Always match the physical procedure to the anatomical station. Remember the blind spots like 4R for the esophagus or 5 and 6 for both.
Pearl 5. A negative result must mean representative nodal tissue was obtained and verified by pathology.
Pearl 6. Reconcile all geographic labels before irreversible treatment. One mislabeled node changes everything.
All right, let's do the board blitz. Live case-style Q&A. I will read the scenario. You break down the answer for the listeners. Question 1. You are reviewing a scam. A suspicious node lies below the inferior boundary of the subcarinal space, tracks tightly alongside the esophagus, and extends inferiorly toward the diaphragm. Which station is this, and practically why does that distinction matter?
That is unequivocally station 8, the paraesophageal station. It is not station 7 just because it sits centrally, because it is located below the defined subcarinal region. It is not station 9 because that station is associated laterally with the pulmonary ligament. The distinction matters massively because station 8 is perfectly and easily accessed by esophageal ultrasound EUS since it hugs the esophagus. Meanwhile, a routine airway EBUS might struggle to get a safe, affected angle on it as the airways diverge lower in the chest.
Perfect. Question 2. Your patient has several suspicious mediastinal nodes on both CT and PT. The absolute hottest, most avid node is in the subcarinal space, station 7. What is the absolute best invasive staging strategy?
The answer is systematic endosonographic staging, utilizing both EBUS and EUS, if relevant, to clear the necessary map. You do not just hit the hot station 7 node and call it a day.
Right, because if you only sample the hottest node, you are falling directly into trap 1.
You might completely miss a occult 4R node that also harbors microscopic disease and urgently needs to be incorporated into your high-dose radiation target volume.
Final question, bringing our case anchor to a definitive resolution. You have a highly PE-avid left upper mediastinal node. Radiology called it 4L. Pulmonology called it station 5. The pathology sample is scant with no malignant cells. Station 7 is adequately sampled and negative. What is the final resolution for this patient?
The resolution is that this case is completely unresolved. You absolutely cannot proceed with treatment. You must anatomically reconcile whether this node is 4L or 5 by sitting down and looking at the imaging directly with thoracic radiology.
Once you know exactly where it lives in 3D space, you have to obtain representative tissue via route that can actually reach it.
An adequate station 7 does not validate a completely non-diagnostic station 5. If it truly is a station 5, you might need to coordinate a surgical Chamberlain procedure to safely and definitively clear this patient for their final treatment pathway.
That is exactly how you synthesize this material safely and effectively. Before we close today's session, we have one final provocative thought for everyone listening, and this is something that twists everything we just talked about into an incredibly complex knot.
Well, this is a good one.
What happens when you have to do restaging after a patient receives induction therapy?
This is the real frontier challenge in thoracic oncology. If a patient gets neoadjuvant chemotherapy or immunotherapy before surgery, their internal anatomy fundamentally changes. The tumor shrinks, dense scar tissue forms, and intense inflammatory changes drastically alter the physical accessibility and ultrasound appearance of the nodes.
You cannot just reflexively repeat the exact same EBUS staging procedure you used initially and expect the same reliability. The prior anatomic roadmap is completely obsolete.
You essentially have to build a completely fresh map from scratch. You review what was originally positive, you look at the interval changes on the post-treatment imaging, and you start the entire logic chain over.
The interpretive uncertainty is exponentially higher because a node might now be dense fibrotic tissue. It might yield a scant sample, not because the pulmonologist's needle missed the target, but because the node is entirely composed of dead, treated tissue with no cellular architecture left.
It requires intense nuanced, multidisciplinary discussion to decide if a repeat invasive procedure will actually yield a trustworthy answer, or if you just have to proceed to surgery based on the clinical response. It forces you to question every single assumption you made during the initial staging.
And speaking of complex surgical decisions, that leads us right into our next discussion topic.
Yes, teasing our next review session: operability, resectability, and surgical principles.
We are going to take this exact nodal data framework we built today and use it to understand exactly how thoracic surgeons decide who gets cut, who gets passed to definitive radiation, and how we measure surgical quality in the operating room.
It is going to be a crucial, highly practical bridge between our specialties.
Get show notes, diagrams, and complete practice oral boards at radonsmartlearn.com and subscribe for our next review session. Thanks for tuning in.